Hi everyone. This is a revision video before the upcoming chapter test, and it will be only dedicated to the heart sounds and the heart murmurs and the ECG tracings. So the first question we might be asked is about S1 and S2. If I say, what does S1 refer to? So S1 refers to the first heart sound. What does S2 refer to? S2 refers to the second heart sound. What is the cause of S1? It's due to closure of the atrioventricular valves at the beginning of ventricular systole. I have to say at the beginning of ventricular systole. What's the cause of closure of the semilunar valves or the second heart sound? It is due to closure of the semilunar valves at the beginning of ventricular diastole. I might ask you to justify why do the semilunar valves close at the beginning of ventricular diastole? Because at the beginning of ventricular diastole, when the ventricles start to relax, the intraventricular pressure drops and becomes lower than the pressure in the connected large arteries. So the pressure in the aorta and pulmonary artery becomes higher than that in the left ventricle and right ventricle, and there is a risk of regurgitation or backflow. And the valves are already, their pockets are full of blood, so they get closer to each other and they close. Now, what are the abnormalities that we might find in a valve? We might find an incompetence, meaning that the valve does not close properly, or we might find stenosis, meaning that the valve is narrower than or has a smaller diameter than normal. The consequences of an incompetent valve are mainly regurgitation or backflow of blood. And when the blood backflows, it meets the forward blood and there is turbulence of blood flow, which results in a murmur. Similarly, stenosis means that the blood will pass through a narrow orifice or opening, and this again results in a turbulent non-laminar flow, which results in a murmur. I might ask you to define a murmur. A murmur is an abnormal heart sound superimposed on S1 and S2. I mean superimposed on the normal heart sounds and resulting from a turbulent blood flow. Now, I might ask you about the diagram and say, for example, what does the diagram represent? It represents an audiogram. What is an audiogram? An audiogram is a tracing of the heart sounds and the possible murmurs that might be present in between the normal heart sounds. So the audiogram is different from an audio. How does an audiogram differ from an audio? An audiogram is a tracing, whereas an audio is a sound like a voice note that you might hear. So in an audiogram, you just visualize the tracings, but you don't hear any sound. I might ask you about the information that you might get from an audiogram. Number one, you can visualize S1 and S2. And you can visualize the difference in intensity between the two, that S1 has a higher intensity than S2, and therefore S1 is louder normally than S2. You might also discover that S1 or S2 are split. They are divided into two small waves. So you might say that S1 is split or S2 is split, but I never ask you about it, about this year. You also see systole, the duration of systole and the duration of diastole. Systole exists between S1 and the following S2, whereas diastole exists between S2 and the following S1. I can also ask you about the difference in duration between the diastole and the systole. So you would say that diastole is longer than systole. I might ask you to justify the fact that diastole is longer than systole. So you would say because diastole is the period during which the ventricles relax, and therefore this is beneficial for two reasons. The first one is that this time of relaxation prevents muscle fatigue from occurring in the myocardium. And this is very important because the heart cannot enter into fatigue. Otherwise, it would be tetanized and it would stop contracting. The second benefit from this long diastole or relatively longer diastole is that it allows adequate time for the ventricles to fill with blood coming from the atria so that when they start systole, they would have a considerable amount or a normal amount of blood inside their cavities. I might ask you about other criteria that might be or other pieces of information that we might get from an audiogram other than the ones we already visualize here. So you might answer that an audiogram will also show us a murmur, a possible murmur. And a murmur, as you know, is an abnormal sound superimposed on S1 and S2. And you would say that if this murmur lies between S1 and S2, it would be a systolic murmur. And in this way, you have defined the systolic murmur. A systolic murmur is a murmur that lies between S1 and S2. You might also add that another type of murmur that might be detected in the audiogram is a diastolic murmur. And by definition, a diastolic murmur is a murmur that lies between S2, the second heart sound, and the coming or the following S1. You might also add, if I ask you about the information that might be deduced from the audiogram, that through the audiogram, through visualization of an audiogram, we can not only differentiate between a systolic murmur that would lie here and a diastolic murmur that would lie there, but we might also differentiate among between different types of systolic murmurs. So we can differentiate a murmur that extends throughout the whole systole from a murmur that occurs only in the middle of systole. So I might ask you to define the holosystolic murmur. A holosystolic murmur is a murmur that extends along the whole systole. So it extends from the end of S1 to the beginning of S2. Another type of systolic murmur is the mid-systolic murmur. How would we differentiate between a mid-systolic and a holosystolic murmur? A mid-systolic murmur is the tracing of a mid-systolic murmur is seen only in the middle of systole. So you would find a space before it and a space after it. The mid-systolic murmur is diamond-shaped. It looks much like this tracing, but here in the middle of systole. So it's a crescendo, decrescendo murmur. The intensity increases and then decreases. I might also ask you about, or let's finish first the rest of the pieces of information that we might deduce from an audiogram. In addition to the systolic murmurs, you might detect on the audiogram a tracing here in this duration of time, which is the diastole. This tracing would definitely be a diastolic murmur. If the diastolic murmur lies here in the middle of diastole, leaving a space before it and a space after it, then it is a mid-diastolic murmur. And it's always a crescendo, decrescendo, or mostly a crescendo, decrescendo murmur or a diamond-shaped murmur. But rarely do we see or rarely do we find here hollow diastolic murmur. Usually, diastolic murmurs are mid-diastolic ones. But we might find another type of diastolic murmurs, which is the early diastolic murmur. If we have an early diastolic murmur, then it will be at the beginning of diastole, and it will be a diminishing murmur or a decrescendo murmur, meaning that after S2 is done and is finished and is heard, you will hear a murmur at the beginning of diastole just after S2 that starts loud and then diminishes gradually. So it is a decrescendo murmur, and it starts loud and diminishes afterward. Of course, you might give examples to strengthen your answer or to give more value to your answer. Or it might be a question on the chapter test, meaning that I might ask you about the causes of a hollow systolic murmur. So you would say that there are two possibilities for a hollow systolic murmur here, taking the whole thickness of systole, the whole duration of systole. A hollow systolic murmur might be due to mitral incompetence or due to tricuspid incompetence. This is the answer. So I might ask you, how can you differentiate between the two? Meaning that you auscultated the patient and you heard a hollow systolic murmur extending from S1 and to S2. How would you know whether it is due to mitral incompetence or due to tricuspid incompetence from the auscultation area? If you hear it in the mitral area, then it is due to mitral incompetence. If you hear it in the tricuspid area, then it is tricuspid incompetence. I might also ask you about the murmurs of stenosis, aortic stenosis and pulmonary stenosis, because we said that if we find a mid-systolic murmur, then this mid-systolic murmur might be due to aortic stenosis or pulmonary stenosis. So if you auscultate the patient and hear a mid-systolic murmur between S1 and S2, not exactly after S1 and not exactly before S2, then it is a mid-systolic murmur and it is due to either pulmonary stenosis or due to aortic stenosis. How would we differentiate between the two from the auscultation area? If you hear it on the aortic area, then it is due to aortic stenosis. And if you hear it on the pulmonary area, then it is due to pulmonary stenosis. And then we have the murmurs in the diastolic period. If you hear an early diastolic murmur, it is due to either aortic incompetence or pulmonary incompetence. And again, we differentiate from the auscultation area. If you hear a mid-diastolic murmur, then it is either mitral stenosis or tricuspid stenosis. And we differentiate from the auscultation area. If it's on the mitral area, then the cause is mitral stenosis. If it's on the tricuspid area, then it is due to tricuspid stenosis. And this necessitates that you know the auscultation areas very well. So here, how can we define the auscultation areas and find them on the human body? We start scrolling down our index finger slightly in order not to cause damage to the patient until we reach this notch, which is called the sternal notch. On both sides of the sternal notch, we have the clavicles, and the clavicles, underneath them, we can find the first rib. And many of you get confused in the diagram between the clavicle and the first rib. No, the clavicle is longer. The clavicle is not curved. The clavicle is, yes, it is, it is angulated, but it does not have an anterior part and a posterior part like the rib. So you descend with your index finger until you reach the sternal notch, which is very easily detected. And then you descend on the first part of the sternum, which is the manubrium sterni. And then you find here like a bump, and that bump is called the angle of Lewis or the sternal angle. The angle of Lewis is almost at the level of the in between the first and second intercostal space. So if your index fingertip is on the angle of Lewis, you have to descend a bit downward and to the right to reach the aortic area, or downward and to the left to reach the pulmonary area. And what's most important is that you never try to listen on the rib itself. We listen in the intercostal space. So the first intercostal space is the space that lies between the first rib and the second rib. The second intercostal space, whether you're talking about the right side or the left side, it is the space between the second rib and the third rib. So we always listen to the heart sound in intercostal spaces. The right intercostal space to the right sternal edge, this is where you can best hear aortic sounds. And so for example, the second heart sound, the aortic component of the second heart sound can be best heard here. And then on the other side, on the left side, we have the pulmonary area. It's again the second intercostal space to the left sternal border. The third intercostal space to the left sternal border, this is Erb's point. And Erb's point is a point of meeting of several branches of nerves in the thorax that are very important. But for the cardiovascular system, Erb's point is important because it is the site where you can best hear sounds of aortic regurgitation or aortic incompetence. And then we have the fifth intercostal space at the left sternal edge. This is the tricuspid area. And then you have the apex, which is the fifth intercostal space, left, and you have to say left midclavicular line, and it is the mitral area. What do we mean by mitral area? It is the area where we best hear sounds originating, whether they are normal components of heart sounds or murmurs originating from the mitral valve, and similarly for the rest of the areas. Now, what is the cardiac cycle? How can we define the cardiac cycle? Of course, anything that is cyclic is like an event that repeats itself regularly and rhythmically. So the cardiac cycle is a sequence of events, and these events are regularly repeated, and the event is alternating contractions and relaxations of the atria and of the ventricles. Of course, we haven't studied the graph of the cardiac cycle in detail. I did this on purpose because you'd better see it at the end when you have understood all the hemodynamics of the heart. When the atria contract, they contract for one simple reason, is to pump blood to the ventricles. When the ventricles contract, they contract in order to raise the pressure enough to pump blood into the corresponding large arteries. The corresponding large artery of the right ventricle is the pulmonary artery, and the corresponding artery for the left ventricle is the aorta. Now, if we put our hand, our palm on the apex, we will feel the heartbeat. So you will feel the thrust or the upward push of, or the outward push of your heart when it is contracting. This is the beginning of the cardiac cycle. And then the second thrust that you will feel, the second force outward that you will feel hitting your palm, this is the beginning of the second cardiac cycle, and the duration between them is the length of the cardiac cycle. As I said, we will postpone the phases of the cardiac cycle to the last minute because we need to associate them with the events of the trace in the ECG and the tracings of the ECG. Similarly, we haven't yet covered the action potential. We just know that the cardiac muscles have a very long, or a relatively long, absolute refractory period in order to protect the heart from fatigue. And now we move on to the important part, which is the electrocardiogram. But before discussing the electrocardiogram, I have to remind you that we jumped a few slides to reach the valvular diseases. So we should review together the valvular disease. First of all, mitral stenosis. What does mitral stenosis refer to? It refers to the narrowing of the mitral valve. So what is the hemodynamic effect in mitral stenosis? The hemodynamic defect in mitral stenosis is that the diameter of the mitral valve is smaller than normal. How can this affect your auscultation? You will hear a murmur because of a turbulent blood flow. And that murmur is a diastolic murmur. What does a diastolic murmur mean? It is an abnormal sound that lies between S1 and the following S2. In case of mitral stenosis, where is the mid-diastolic murmur best heard? The mid-diastolic murmur is best heard in the mitral area, and you have to define the mitral area. And here you have a diagram that shows you the difference between a normal mitral valve with a normal diameter. I might get you the diagram and ask you what's wrong about the mitral valve here. The mitral valve is narrow, as you can see in the section, and therefore there is resistance to blood flow. Can this be, if we get a higher level question or a higher difficulty level question, how is this reflected on the heart? Of course, if the mitral valve is narrow, then this will result in enlargement of the left atrium because less blood will flow per unit time to the ventricles, and it will result in diminished arrival of blood to the ventricles, which will definitely diminish the volume of blood that is output to the aorta. In case of mitral regurgitation, what is the hemodynamic effect? This is a question. What is the hemodynamic effect in case of, I wouldn't say in case of mitral regurgitation, I would say in case of mitral incompetence. So the hemodynamic effect is that the valve is incompetent. And when the valve is incompetent, it does not close perfectly. And when the valve does not close perfectly, this will result in back flow of blood into the left atrium. And we have to say when. It results in backflow of blood into the left atrium during left ventricular contraction. Why are we specifying during left ventricle or ventricular contraction? Because the mitral valve is on the left. Why are we specifying that it is during systole? Because while the left ventricle is contracting during systole, the pressure increases. And if the mitral valve is not closed perfectly, as you can see, the blood will regurgitate or backflow into the left atrium, resulting in a systolic murmur, as we said before, a holosystolic murmur. Where is this holosystolic murmur best heard? It is best heard over the mitral area. And then we have tricuspid stenosis. Tricuspid stenosis is the opposite. We have narrowing of the tricuspid valve. So the blood will, instead of flowing, as you can see here, through a normal tricuspid valve from the right atrium, and by the way, it is from the right atrium above to the right ventricle below, it will flow through a fibrotic, narrow, stenotic tricuspid valve from the right atrium to the right ventricle, and therefore there will be accumulation of blood in the right atrium. And because of this narrow orifice or opening, there will be turbulent blood flow that will result in a murmur, and that murmur will occur during diastole because it's this diastole when the right ventricle is receiving blood. So the murmur of tricuspid stenosis is a diastolic murmur, mid-diastolic murmur over the tricuspid area. Now, in case of tricuspid incompetence, it's exactly the reverse. Incompetence means that it does not close perfectly. This is the normal tricuspid valve on the right side. So when the right ventricle finishes its diastole and starts systole and starts contracting and pumping blood into the pulmonary artery, of course, deoxygenated blood, this valve should be completely closed. If the valve does not close perfectly, this means that it is an incompetent tricuspid valve, and in such a way, when the right ventricle contracts and raises the pressure inside, not all the blood will pass to the pulmonary artery, but a fraction of the blood will regurgitate into the right atrium. And that fraction will depend on how incompetent the valve is. Of course, the more incompetent, the wider it is, the more the backflow. This backflow has a harmful effect on the right atrium, yes, because it enlarges the right atrium, and meanwhile, it diminishes the remaining fraction of blood that will be sent to the pulmonary artery. Now, concerning aortic stenosis, I might ask you about the definition of aortic stenosis. You would say it's an aortic valve, a condition where the aortic valve has a diameter that's smaller than normal. I might ask you about the defect in case of aortic stenosis, the hemodynamic defect. The hemodynamic defect is that hemodynamic means how it affects the blood flow. So when you have aortic stenosis, this simply means that when the left ventricle starts to pump blood into the aorta, the left ventricle finds resistance to the blood flow into the aorta. And therefore, we hear a murmur, which is a systolic murmur over the aortic area. Of course, it's not enough to say the timing of the murmur, but you also have to mention the location of the murmur. In case of aortic incompetence, in case of aortic incompetence, what is the defect? The defect is that the valve is incompetent, that the valve does not close properly. I'm talking about the aortic valve. So this is a question, how can aortic incompetence affect the hemodynamics of the heart? When the aortic valve is incompetent, this means that it does not close properly at the beginning of diastole of the left ventricle. And what happens is that there will be some backflow of blood, downward flow of blood at the beginning of diastole, and this results in a turbulent blood flow in the form of an early diastolic murmur. And it's not enough to say early diastolic murmur, but over the aortic area. Concerning pulmonary stenosis, if I ever ask you about the defect in pulmonary stenosis, it's a pulmonary valve that has a smaller diameter than normal. Like, what are the hemodynamic abnormalities or the hemodynamic consequences in case of pulmonary stenosis? It's that when the right ventricle starts pumping during systole, trying to push the blood into the main trunk of the pulmonary artery, it will find resistance to flow because the valve is narrow. So you will hear a murmur during systole, and that murmur of pulmonary stenosis is a mid-systolic murmur. And where is it located? It's not enough to say that it is mid-systolic, but we have to say the location. So it is a mid-systolic murmur where over the pulmonary valve. And then last thing is the pulmonary incompetence. In case of pulmonary incompetence, the problem, what is the hemodynamic or what is the defect in case of pulmonary incompetence? The patient has an incompetent pulmonary valve. The patient has a pulmonary valve that does not close perfectly when the right ventricle starts its diastole. Like, what are the hemodynamic consequences of pulmonary incompetence, it is that we hear an early diastolic murmur where, again, location over the pulmonary area when at the beginning of right ventricular diastole. So whenever you describe the hemodynamic abnormalities or consequences of a valve disease, you have to say that there is a murmur, you have to mention the timing of the murmur, you have to mention the location of the murmur and the quality if possible, like rumbling murmur in case of mitral stenosis, and you have to mention whether this occurs at the beginning of systole or diastole and on which side, right side or left side. This is the first part of the video, and the second part of the video will be questions and answers about ECG.